Just want to welcome those logging on virtually. We'll start in about 30 seconds or so. Great. So welcome. Good afternoon. I'm David Perez, and it's my pleasure to kick off our second annual Sidney R. Baird Jr. Foundation Grand Rounds in Behavioral Neurology and Neuropsychiatry. This endowed lectureship puts a spotlight on clinical, research, and educational activities at the intersection of neurology and psychiatry. Today, we're very pleased and fortunate to host Professor David Arciniegas from the University of Colorado. Professor Arciniegas is an international expert and scholar in traumatic brain injury and the subspecialty of behavioral neurology and neuropsychiatry. He has obtained more than 20 federally funded research grants, has authored or edited 8 textbooks, and has published over 150 peer-reviewed articles. Professor Arciniegas co-led the development of the subspecialty certification in behavioral neurology and neuropsychiatry through the United Council for Neurological Subspecialties. He's received numerous awards, including receiving the Innovative Clinical Research Award from the North American Brain Injury Society. He's the immediate past president of the American Neuropsychiatric Association and editor-in-chief of the Journal for Neuropsychiatry and Clinical Neurosciences. On a personal note, Dave, Professor Arciniegas, has been a wonderful mentor, friend, and colleague. Please join me in welcoming Professor David Arciniegas.
Thank you, David. Thank you for the kind introduction. Thank you all for being here and to our organizers for inviting me to offer the Sidney R. Baird Jr. lecture. I'm really pleased to be here. It's been a long time since I've been at Mass General and couldn't be a better occasion to be back. I also want to say hello and to all of our friends and colleagues joining us virtually. I hope that the next hour or so will give us an opportunity to not only take a little bit of a dive into the area that is on the title, Cholinergic Function and Cognition After Traumatic Brain Injury, a bit of a specific area, but as you'll see, perhaps one more relevant to a lot of the care that we deliver to persons with traumatic brain injury than may be sometimes appreciated. But also at David's request, a few moments to talk about TBI neuropsychiatry, and here in the Jeff Cummings-esque sense of neuropsychiatry, evenly tenored both sides, because particularly in this context, that really is something we need to bring to bear to the care of persons with brain injuries. By way of some housekeeping details, here are your CME elements, including the learning objectives, talking much about what is in the title and what I just said. If you need the QR code, especially if you're looking at it on a small screen in a conference room somewhere, I hope the bigger version will work. And for attendance, text 110525 to the number that you see there on the screen. As regards disclosures, this one was easy, Carol. There are none that are relevant. So let us move on then to talk a little bit about what we're going to do this afternoon. I will provide just a brief introduction to TBI and to TBI neuropsychiatry. In an audience like this, I'm sure everybody has substantial expertise in TBI, having it become a major area for neurology over the course of the last 30 years, but it never hurts to set the terms. And as I mentioned, we'll talk a little bit about TBI neuropsychiatry, including some that's directly relevant here at MGH. And then I will provide from my clinic a context into why explore this relationship between cognition and cholinergic dysfunction after TBI. Talk a bit about cerebral cholinergic systems and the effects of TBI on them, as well as then a series of studies that have actually led to the evidence base for using this in clinical practice presently. And then a little bit about how that exercise in translational neuroscience observations made in the clinic or at the bedside, taken back to the lab, and then worked their way back into clinical trials could be a really nice model for those of us doing clinical work as our approach to the science that we do. So, by way of brief definitions, I have heard over my 30 plus years of doing this, David, the argument from some that there's no definition of TBI. This turns out not to be true, hasn't been true since the early 90s. House Resolution 5907, the TBI Act of 1992, which then becomes a 96 public law, 104-166, set in motion in the US the federal definition of TBI, informing both DHHS supported clinical services as well as the research enterprise that has flourished over those years. In short, biomechanical force application that produces an immediately apparent disruption of brain function and or structure, and that has at least some transient disability associated with it, whether that's just in the moment and quickly recovers or for many lasts somewhere thereafter, weeks, months, often years. That definition was then formalized by the American Congress of Rehab Medicine in 1993, operationalized to say, well, what is that alteration in brain function? Well, after biomechanical force application, any period of loss of consciousness, any period of lost memory for the events, whether anterograde or sometimes a little bit of retrograde, other alterations in mental state, or focal neurologic deficits that are clearly related to the biophysics of that force application. And this really has become the standard setting for TBI definitions internationally then over the last 30 years. With a couple of now very recent updates expanding and or making more precise how it is that we think about that. From Noah Silverberg and Grant Iverson, and then a whole crew of people from the American Congress of Rehab Medicine, a more formally operationalized set of criteria to walk through to determine if, in fact, either at the time or after the event, a TBI has occurred. Interestingly, applying a logic very much like that in Alzheimer's disease of possible and probable, here with TBI more definitive based on the history or suspected, and setting some criteria for what is the minimum level required to say at least a mild TBI has happened, and then what's in excess of that, something moderate, severe. From Jeff Manley, Kirsten Dams-O'Connor, and a large crew, largely coming out of track TBI, but really a much larger now NIH, NANDS TBI classification and nomenclature initiative, the CBIM model, clinical biomarkers, imaging, and then modifiers, where all of those things are then incorporated into our characterization of acute TBI and then expectation setting for recovery thereafter. Importantly, I'll call your attention to the modifiers echoing over now more than 100 years an emphasis on not just the injury, but also patient factors, and then more recently, as we'll see, social and environmental factors, the psychosocial context in which the injury occurs, and that may then continue to evolve thereafter. How those more recent definitions will change the epidemiology has yet to play out, but for the time being, what we think we know is it is indeed a very common occurrence. 2.5 million ED visits a year or more for a TBI, more than 200,000 hospitalizations, with classical estimates of TBI suggesting about 80% would fall into that AC or a mild category, 8% more than that in the moderate range, about 2% severe, some 10% from the CDC not being easily classifiable based on the records in the surveillance systems. As we think more about concussion and that many people don't make it to the hospital, let alone into the hospital in order to be so classified, it's probably closer to 90 plus, maybe even more than 95% are really in the mild TBI concussion category. And what that means in terms of prognostics actually ends up being more favorable than sometimes we think. The debate about how many people after mild TBI or concussion end up persistently symptomatic is a rather charged one in this field. But suffice it to say, with that data, it would still suggest that on balance, concussion, mild TBI is a good prognostic event. Those prognoses do change a bit as we increase the initial severity of injury. It's a trimodally distributed problem, less than 5 in the teens and young adult years, and then after age 65 being the peaks that we see, with men or boys outweighing women or girls in the extremes of age and, in the first two categories, the young and the young adults, and then in later life equal. And this epidemiology has changed over the last 30 years. When I started doing this, motor vehicle accidents were thought to be the #1 cause based on the population estimates. Now it's actually falls, and then falls, including in the young and the very old, with then being struck by or against and motor vehicle accidents having fallen as the population has aged and falls take a larger portion of the injury incidents. And it is costly in every sense of the word. It's costly in terms of years of life, with an average reduction after hospitalization requiring TBIs of 4 to 7 years. Most of that excess mortality occurring in the first 5 years after injury, but not solely. A leading cause, not the, but a leading cause of disability, with a little more than 1% of the US population actually living with chronic sequelae of TBI to a degree that it changes their ability to meet the demands of everyday life. Extremely expensive with indirect and direct costs, placing it in the current era more than $100 billion a year. And interestingly, with a significant chunk of that cost coming from the neuropsychiatric sequelae of TBI. Adding neuropsychiatric disorders as sequelae or significant comorbidities increases the costs of TBI about threefold. Giving us some moments to pause on the importance of then TBI neuropsychiatry as an interest area. Now, for those who don't know the American Neuropsychiatric Association, some of the principles of which we have here with us, Dr. Schmaman, Dr. Dixon, Dr. Perez, Dr. Scharf, and in my recent years, this as well. We have a special interest group if this kind of area is something you'd like to engage with more fully. But over the last 30 years, it has become an important part of our field more generally. Dr. Silver, John Silver, with Stu Yudofsky and Bob Hales initially, in partnership with Dr. McAllister and myself more recently, have bookended an awful lot of emphasis on the cognitive, emotional, and behavioral sequelae of TBI as a key interest area for persons working in the, again, Cummings-esque field of neuropsychiatry, whether coming from the neurology side, the psychiatry side, or both. And interestingly, in part because this is in fact where the term and the field neuropsychiatry begins. Less commonly credited than perhaps it ought to be, neuropsychiatry is a distinct field, with the word having been coined only in 1917 and then first put into the literature, according to the Oxford English Dictionary, in 1918, begins with the US Army in World War I. And specifically with Chief Surgeon Theodore C. Leister, who actually took a group within the American military and brought together neurology and psychiatry to deploy in the American Expeditionary Forces in Europe, principally for the evaluation and management of three main problems that had actually vexed the service ability to care for them: shell shock, now PTSD, concussion, including what we would now think of concussion and contusion, collectively traumatic brain injury, and the war neuroses, functional neurologic disorders, and a number of other stress-related conditions, as well as to then take that understanding of what happened after being deployed in service and incorporate it into military-wide pre-service screening for neurologic and psychiatric conditions, as well as the evaluation and management of these and other service-related neuropsychiatric conditions thereafter. And indeed, by August of 1918, 16 departments of neuropsychiatry had been established along the American lines of communication. I think this is actually a quote from these reports from the U.S. Office of Medical History, now AMED, that echoes maybe a little too loudly in the modern era, that it was, at their experience at the time, one of the outstanding features of this new group, this new neuropsychiatry, was that neurologists and psychiatrists shared one another's duties, responsibilities, and point of view to an extent that had never previously existed in civil life, and that these new terms, neuropsychiatry and neuropsychiatric, came to have ample justification for the use. That said, it was true, nevertheless, that relatively few medical officers possessed equal qualifications in both these fields. The psychiatrists had not enough neurologic training to attend to some of the focal neurologic disorders and other interesting or perplexing questions in diagnosis and treatment at the base hospitals. On the other hand, many neurologists had devoted themselves so exclusively to those things that they were insufficiently prepared to care for patients with acute mental disease, and I love this part, to apply with much conviction some of the psychological viewpoints upon which the treatment and prevention of the war neuroses were largely based. It'd be nice if that had changed a little bit, Dr. Perez, but we're working on it. We're working on it. Suffice it to say, they actually came up with a plan and a curriculum for integrated neurologic and psychiatric training to be provided to that cadre of physicians coming into the neuropsychiatric service. That became the curriculum that the AMA section on nervous and mental disease advanced over the next decade, with Peter Basso leading the charge, and that actually became the foundation for the American Board of Psychiatry and Neurology's proposed criteria for qualifications in these fields in the early 1930s. What they had done essentially is develop what Studiotovsky and Bob Hales referred to as the umbrella discipline, this transdisciplinary field of neuropsychiatry, bringing neurology and psychiatry together in core elements to do that work. Interestingly, the first book in neuropsychiatry turns out to be by Mabel Webster Brown, a librarian for the National Committee for Mental Hygiene based in New York, taking then the literature from Britain, France, Germany, Italy, the Netherlands, Russia, Scandinavia, and the US, and compiling it based on this new lens of neuropsychiatry through which to see the consequences of war, with this bibliography and abstracts published in 1918. For those who like history, if you look up neuropsychiatry, get to the OED's citation of it first appearing in 1918, this is where Chasing That White Rabbit takes you, is to Mabel Brown. Of course, it also has echoes here at MGH, with Stanley Cobb in his preface to Nervous Disease in 1936, especially in the sections on consciousness, speaking to the effects of concussion thereupon, and then Lowell Selling in 1944, taking it with a specific focus on concussion, contusion in clinical practice and in the forensic work that he did in Detroit. Contemporaneously, Sir Charles Symons, in his later years, Vice Admiral of the Royal Air Force, Sir Charles Symons, British neurologist, sets the stage for what then becomes a theme that TBI neuropsychiatry has tried to bring to this work, making first the case that in his view, the two extremes of what we may say after effects of concussion and or the acute traumatic psychosis, what we would now call post-traumatic confusional state, really are continua. He saw, as he says, no difference between the two, but the long drawn-out cases, of course, offering the greatest opportunities for observation. And from his position as a neurologist, makes the case in his paper in 1937 that in order to really understand the outcomes of TBI, one needs to consider more than just the injury. Indeed, one needs to undertake a full psychiatric study of the individual patient. In his language, it's not only the kind of injury that matters, but the kind of head that was injured. This, with Dr. McAllister and Dr. Silver, then as a heuristic that we have attempted to apply foundational to TBI neuropsychiatry, but applicable to many other areas of the work that we do in behavioral neurology and neuropsychiatry. My dad recently departed as a pediatric cardiac surgeon, looked at this slide when I showed it to him some years ago, and his only response was, "Oh my God, it's so complicated." It's like, well, yeah, it is. Not that what you don't do isn't complicated, he said in a surgical auditorium. It is, but this is quite challenging, but it's dissectable. The basic idea being that as we begin thinking about TBI and how to approach it, of course, we begin with a person who moves into an injury event by a mechanical force application, that force application affecting systems in the brain, subserving cognition, emotion, behavior, and sensory and motor function. And that person's vulnerabilities and resiliencies may modify to some degree, if not the injury itself on those systems, but the way in which it immediately responds and or early on recovers. As somebody who spent most of his career thinking about cognition after TBI, it would be lovely if in fact each of these boxes remained separate from each other. But as Dr. Symons suggested, not so. And indeed, they interact quite robustly with one another, as we'll see a little later on in the talk, especially in the context of understanding cognitive outcomes after TBI, considering in particular depression, anxiety, PTSD, pain, and related problems is absolutely critical to understanding the cognitive presentation and whether or not that is in fact where, if you will, the money is at in terms of trying to help get people better. Those things then intersect to produce the laundry list that you see on the right of common consequences of TBI, things for which people present for clinical care, and expanding Symons It also then matters what happens at the time of injury, treatment received, not received, other complications and comorbidities, other services provided, not provided, family support, expectations, things like litigation, that then can either modify in a good way to facilitate recovery or interfere, compound it, and result in prolonged symptoms. This then being a cornerstone to the work that we do in BNNP. A particular application in TBI, but as you think about the work you do, if that's not what it is, one that probably applies relatively broadly as a heuristic for approaching the clinical challenges that we see in persons in our clinical practices in neurology, psychiatry, and BNNP. To point to them. The tale that I'm going to tell about cerebral cholinergic function and cognition after TBI really begins for me with John Silver's book, which I got when it came out in 1994, a dedicated read-through, and an application then in the neuropsychiatry clinic that I had started at the University of Colorado in 1995. With that book as my guide, taking a comprehensive neuropsychiatric approach to the evaluation of patients with all the things you see here, history-taking exam, including exam for neurological subtle signs, mental status exam, cognition, imaging, EEG, other laboratory studies, and collaboration, intense collaboration and training in neuropsychology. And out of this emerged for me a pretty consistent observation that while people were typically coming in to see me for problems with attention, memory, and executive function, it was noteworthy that they were often describing context-dependent challenges with it. That at baseline after the injury, things had not worked quite as well as they had prior to that. But if they went out into an environment where there were multiple competing stimuli, often they were not distracted by the other stimuli. They were unable to focus on the thing that required their attention, brought their list to the grocery store, but really couldn't focus on anything, the list or otherwise, because of sensory overload, visual and especially auditory. And interestingly, this seemed to obtain irrespective of the initial injury severity. When that problem was present, they were markedly impaired in their ability to meet the demands of everyday life in the kinds of environments in which it occurs. Now, I had been working at the time with Bob Friedman and crew as a resident in their Schizophrenia Research Center. Sensory gating was, in fact, the cornerstone of what Bob and his group did. They'd outlined a wonderful set of not only phenomenologic evaluations, electrophysiologic, then anatomic and genetic. The short version of which is that they regarded sensory gating as a preconscious cortical function, helps you filter out multimodal stimuli to focus the lens of attention and then memory, executive function, and so forth on that which is relevant, most of the time operating outside the realm of consciousness. Given what your cognitive goals are, your behavioral goals, the lens focuses and does this automatically for you. Noted that it was phenomenologically distinct from distractibility. For gating disturbances, unlike distractibility by metaphor, being, if you're the driver, listening to the radio in your car, the passenger changing the station every few seconds, giving you a few seconds of very robust focus on something only to move to something else a moment later. This is rather more like, for those of us who remember older school radios without digital tuning, being out in the country and finding the radio now playing information from two stations. All of it mixed such that a way that it's very difficult to filter the one you want to listen to out of the one that is also concurrently playing, and noted that it was cholinergically dependent. The electrophysiologic paradigm they'd used to index this was the P50 evoked response to paired auditory stimuli. Laying in a room, looking at an X on the ceiling, vertex electrode, VEOG, HEOG, ground, ref, and you hear two clicks, half second apart. White noise, the initial or conditioning click, giving you an amplitude at about 50 milliseconds, typically between 50 and 70, which in response to the second click is attenuated, this being gating. Non-gating, that first click evokes the initial amplitude, and then it is not only not gated, it's often amplified, as if once the gates are open, the information comes through in a way that is for many overwhelming. They had outlined from animal studies and then anatomic studies in humans this architecture. The idea is you're looking at a slice of the hippocampus and then shrinking down the CH1, CH2 cholinergic nuclei projecting retrofornically into it. A cholinergically dependent circuit. You need to have these cholinergic fibers actually coming in and synapsing on a CA3 pyramidal neuron and a GABAergic interneuron. At that interneuron, in particular an alpha-7 nicotinic receptor, being the one that will actually help bring it on when it's required. As information comes down the perforant path to the dentate gyrus, it then quickly synapses to CA3, CA1, and out the subiculum to continue creating that loop that will help capture information and begin laying it down as new memory. Concurrently, that intercurrent projection to the GABA neuron then activates it. It produces GABA that then inhibits that CA3 from firing and shuts the circuit down after the first piece of information comes through to allow it to finish processing it before admitting new information. They thought the foundation of the gate, this sensory gate. Quite elegant. It turns out in schizophrenia, this goes awry because that alpha-7 nicotinic receptor has a dominantly inherited mutation that renders it not non-functional, but less than ideally functional and keeps the gates from turning on effectively. Notwithstanding the amount of nicotine you get out of a single cigarette, professional smoking becoming too often the case in persons with schizophrenia, that will actually allow it to activate with the first cigarette of the day, but then without 4 or 5 hours of respite from activating it, keeps it off the rest of the day. The initial powerfully reinforcing turning on of the gates and reducing, among other things, auditory verbal hallucinations is lost but chased thereafter. The question, hearing that gating problem in clinic for me was, I sincerely doubt that everyone I'm seeing has an alpha-7 nicotinic receptor mutation, but I wonder if those fibers might actually be lesioned. Could this be another way of actually getting to sensory gating problems after TBI? In short, is there impaired sensory gating in this population? Has it really been demonstrated? If so, what's the evidence? And is there some suggestion that there is cholinergic dysfunction after TBI such that this might actually be the foundation for it? And if that's the case, he said, knowing that cholinergic drugs were actually in development, cholinesterase inhibitors in particular, might this actually become a foundation for fixing the function of the system? So I went back to my office. I'm sure everybody knows this already, but if you haven't memorized everything about cholinergic function in the human brain, I hope you'll indulge just a couple of minutes of review, maybe. So what did I come to learn? I'm going to give you a big picture view of not everything I learned initially, but what I think we need to know to make sense of this story. From, among others, Marcel Mesalem and colleagues who've spent many years developing this, an extracted view of it. You can think about acetylcholine in this way. First, that there are 8 discrete cholinergic nuclei in the brain, each of which has a distinct projection pathway, as well as cholinergic interneurons of the striatum. What do? Well, let's start with the brainstem and move our way up. CH5 and CH6, pedunculopontine and lateral dorsal tegmental nucleus, function as an integrated complex projecting up into the thalamus, as we'll see, principally to help support wakefulness, to turn the system on and help you get ready to engage in information processing. CH1, CH2, septal nucleus, vertical limb of the diagonal band of Broca, project retrofornically into the hippocampus to help support its functions. More on that in a moment. And CH4, the basal nucleus, what we sometimes think of as the nucleus basalis, have a number of projections, but for the purposes of our discussion, cognition, mostly the lateral pathway, which has 2 divisions that project to support insular, frontoparietal, and dorsal frontoparietal, temporal, lateral temporal, and other areas. The neocortical supports, if you will, for much of our more complex information processing. Because it will be relevant a little later on, I'll just, for the moment, also highlight the projection from CH4 into the amygdala and to some of the paralimbic areas that are actually responsible for emotional regulation as well. Again, because it'll be even more important for the purposes of our thinking about some of the clinical trials, the pathway that was of direct interest to me in relation to sensory gating, as well then with declarative memory, was this CH1, CH2 retrofornically to the hippocampus. With me so far? All right. From our neuropharmacology in medical school and beyond, as I've already mentioned, nicotinic receptors are a big part of the picture for gating, but most of the work of acetylcholine actually happens at muscarinic receptors, both pre and postsynaptically in the brain. Bottom line is they help facilitate excitation or inhibition very much depending on where they're located, what receptor type, and in what systems. So it may be more useful to think about the role of acetylcholine from a larger lens above receptors. What's its role? It's a modulatory neurotransmitter, of course. I think metaphorically, it's useful to think of acetylcholine as the oil to the gas or other fluids that are elsewhere in the brain. In particular, glutamate being the primary accelerator, if you will. The job of acetylcholine is to help you get more action from glutamate with less of it. Higher levels of glutamate becoming excitotoxic, something to modulate or potentiate its action and use less glutamate will result in less risk of neurotoxicity from those actions. As we've already seen, is going to help facilitate the work of GABA and bring it available to be the brakes and on that engine, if you will, as quickly as is necessary with the least amount of GABA so as to not have oversedation come from its being released. Similarly with dopamine, norepi, serotonin, the role of acetylcholine is to potentiate the effect to get more with less. From a brain behavior perspective, what that really means is the reticular formation with CH5-6 supporting it is supporting wakefulness and awareness. Entorhinal hippocampal complex with CH1 and CH2 has cholinergic tones supporting gating, attention, working memory, and explicit memory. And from CH4, especially in its dorsal and lateral projections, these areas of more complex, sustained attention, working memory, language, executive function, visual spatial function, into the projections of the lateral orbitofrontal cortex, social cognition. That'll be important in a little while. And then into the anterior cingulate system, motivation, the drive to sustain thought, feeling, and behavior towards goals. Equally importantly, again, will be relevant for making sense of clinical trial data, there is a sweet spot for cholinergic tone. There is, once we're awake, a tonic release of acetylcholine within a relatively narrow window. Phasic releases can increase the amount available within the systems that require it to improve the efficiency of information processing. Under conditions of disease or injury, think degenerative diseases in which cholinergic neurons are lost, or as we'll see in TBI, as in also in stroke, we may lose some of those cholinergic neurons and decrement information processing efficiency as a result. The treatments that we use to try and enhance cholinergic tone are intended to get us back into that window, but it is, again, a relatively narrow one. The problem with either exceeding it or worse, using the medicines that increase cholinergic tone in patients who don't have cholinergic deficits, is that it's quite easy to go over the top. And once having done that, we will actually decrement information processing. We can, in fact, make things that weren't working well worse by virtue of assuming they're related to cholinergic deficit and using a cholinergic medicine when, in fact, there's no indication or no structural or functional anatomic basis for its use. That then takes us to regulation of the system. There are multiple ways that it is regulated: presynaptic mechanisms at muscarinic and nicotinic receptors, the autoreceptors, regulation by other neurotransmitter systems, and most importantly, intrasynaptic metabolism or hydrolysis by acetylcholinesterases. And in the current era, that's mostly where we're able to do our work of augmenting cerebral cholinergic function by inhibiting that intrasynaptic metabolism with one or another of the acetylcholinesterases. All right, I'm sure that was a review for everybody, but if not, I hope there was something useful in the brief tour through that anatomy, that neurochemical anatomy. Now, what about TBI? Right, so this could be a couple of hours unto itself. And thinking that maybe not everybody's going to be quite so hip to that, let me just tell you, if you really want to go down this rabbit hole, a little over a decade ago, wrote a review of this for Journal of Head Trauma and Head Trauma Rehab, two-parter looking at this very topic. The part one is what we just went through. Part two, the evidence from basic and clinical investigations. Long story short, cholinergic dysfunction after TBI has been the longest standing area of neurochemical investigation in TBI, beginning in the 1940s with CSF sampling and then processing for cholinergic metabolites. This area flourishes in the 80s and 90s as experimental methods of looking at trauma and then looking at these systems further developed. The short version of what we learned from those is number one, applying concussive forces in rats produces an acute activation of those cholinergic neurons, especially CH1-2, CH4, CH5, and 6, and puts the entire system into overload. That having been done impairs cerebral function in a very broad way, and interestingly, induces cataplexy, sudden loss of motor tone that's characteristic of concussion with loss of consciousness. Enough so that Hayes and colleagues in '86 actually have this as the foundation for their proposal of the Pontine cholinergic system of hypothesis. It would have been lovely if this had been the answer, as our own earliest work in the field had actually suggested that we didn't really understand the mechanisms of loss of consciousness. Those giants that I talked about, Simons and others, wondering how to explain it, this was part of that idea. It's much more complicated than this, but this is a contributor. It turns out a lot of that adverse effect of excess cholinergic release can be mitigated by administration of cholinergic antagonists, scopolamine in particular, before injury, and that actually tends to reduce, if not obviate, the development of both acute and chronic post-injury memory problems. It also turns out if you then let those animals recover from their injury, and providing them with a otherwise innocuous dose of scopolamine reinstantiates their deficits almost to the level that they were at the time immediately after injury. Why does that matter? Well, it suggests that even among the recovered animals, they have lost cholinergic reserve, such that a relatively otherwise innocuous dose in an uninjured animal reveals their inability to have enough acetylcholine to keep functioning despite it. And in the absence of any kind of pre-injury neuroprotection from that cholinergically mediated excitotoxicity, they develop chronic reductions in cholinergic function. The magnitude of that, nicely demonstrated by Schmidt and Grady, is somewhere between a third and just short of half of cholinergic neurons lost in CH1, CH2, and CH4. Lateralized injuries produce deficits to that degree on the side of injury, and on the contralateral side, about half that amount. Interestingly, in these animals that they studied, no loss of brainstem cholinergic neurons. So while they're put into excess and produce functional disruptions, they don't structurally damage those projections long term. And even more interestingly, especially given the enthusiasm for dopaminergic therapies in TBI in the modern era, no losses of dopaminergic and noradrenergic neurons. Turned out, further studies suggest almost every aspect of the system that I've actually went through with you from an anatomic and a regulatory standpoint is taken offline to some degree by injury in these animal models. Also importantly, while that's true, a number of studies using cholinesterase inhibitors as well as muscarinic agonists demonstrate that those deficits instantiated by TBI in these animals are at least partly remediable with cholinergic augmentation. In the human area, three forces that we think about: inertial forces, including translational and rotational, to combined leading to angular acceleration forces; contact forces, as brain abut structures within the inner table of the skull, both then lead us to have a cytotoxic cascade. And in most diagrams of this, glutamate gets all of the credit for making things worse. It does do that, but it does not do that in isolation. And indeed, those same forces that I've mentioned for the cholinergic story apply to all of these systems. Stretch strain forces mechanically deform ascending axons. Anywhere you find them will cause them to produce action potentials, and as Tracy McIntosh described it, produce a neurotransmitter storm at the time of TBI. From human studies, Markianos et al. In '96 and '98, most interestingly, sampling CSF from injured persons in the ICU were able to demonstrate that that is true. But interestingly, most of those successes in severe TBI wane within the first 2 to 3 weeks post-injury, such that they return to relatively normal levels of dopamine, norepi, serotonin. Interestingly, one of them actually looked at histamine, but not acetylcholine, at least not for everybody, such that after mild and severe TBI, as consciousness and cognition begins to improve, these things wane and normalize, except for a subgroup who seem to develop chronic problems with cholinergic tone. The Glasgow group in the late 90s and 2000s actually looked at this in people who did not survive their injuries, but had survived long enough to actually have a range of outcomes as relates to this system. They used choline acetyltransferase as a marker for viable cholinergic neurons, showed reduced frontal, temporal, and parietal levels of that, and bilateral reductions that persist for weeks after TBI. Interestingly, like Schmidt and Grady, with an average range of about 40 to 50% neurons lost in half to 2/3 of those with these mostly severe TBIs. Those losses being greatest in those who survived longest, suggesting the process was ongoing. Unlike the animal studies, receptors, M1, M2, and the A4 beta 2 alpha 7 receptors they surveyed were intact. This is good news for us as clinicians because it would suggest that in humans, while there are reductions, not complete, but reductions in cholinergic neurons and their projections, there remain potential targets for intervention if we can actually use our neuropharmacology to improve those systems. Importantly, more modern studies have demonstrated that CH1 and CH2, the projections to the hippocampus, the thing that started me wondering about this as related to gating, are selectively vulnerable. Like all cholinergic fibers, they are unmyelinated. John Pawlshock and crew, but for this slide, if you want to learn more about this from Reeves et al. In 2012, demonstrate that these unmyelinated fibers, especially those projecting retrofornically, are selectively vulnerable to reduction after TBI, suggesting that indeed this part of the story might actually be an important one for us to have attended to. Now, I wish I'd known that in '99 when I started doing it, would have actually obviated a whole bunch of other studies that we did. But suffice it to say, I had the good fortune to be supported by the VA to actually investigate this hypothesis. We had people, adults, history of TBI exceeding or meeting the ACRM criteria at least a year prior to study, went out of our way to remove the other conditions that might have actually better explained or at least contributed to the presentation they had with cognitive and other neuropsychiatric symptom problems. So no categorical psychiatric disorders, no categorical substance use disorders, no other comorbid neurologic outcomes, no seizures, had the problems that they developed with auditory gating and then attention and memory from the moment of injury forward, and actually looked pretty good. The kind of folks who come to see us in clinic saying, I'm not the same as I was, I need help. We did a series of studies that actually demonstrated, one, that P50 problem is actually present. Number two, hippocampal volume reductions are associated with it and are disproportionate relative to volume reductions elsewhere, including to whole brain. That cholinergic hypothesis also is supported in a double-blind, placebo-controlled crossover design study where we administered donepezil to the P50 gators and were able to reverse, in part, between 30 and 60%, depending on dose, the sensory gating problems, the physiology related to it, and other cognitive symptoms. And with that, we're actually able, with a whole head EEG study, to see that, in fact, although Friedman had been looking at the electrophysiology from vertex electrode, as I mentioned earlier, there's very clear bifrontal activations, the vertex electrode, and to the extent that this, with some fMRI work that my colleague Jason Tregellis in Colorado did, actually integrates across conditions in which gating is an issue, really suggests a DLPFC hippocampal thalamus network for managing gating that is taken offline after TBI. Other concurrent data here from Salmon and colleagues in Marie Salmon in Cambridge was able to take cognitive problems and with a voxel-based morphometric study actually demonstrate in red reductions in areas that are cholinergically supported, among other things, but in blue, reductions in voxel-based morphometric assessments of that retrofornicale pathway, as well as the lateral capsular pathway. They also were able to demonstrate that these problems obtained at least out to 3 years post-injury, the notion being extending the Glasgow group's work. Once these are present, they stay present. That selective reduction, vulnerability, and loss of neurons in this system becomes a part of the chronic neurobiology of TBI. Ali Tenevuo and colleagues in Finland extend this looking at an acetylcholine analog in PET studies and demonstrate, again, widespread reductions in what looks like cholinergic tone across the neocortex, and in particular, in the frontal reductions, ones that predict responsiveness to rivastigmine. So from that network that I just showed you, this suggesting an anatomy that might actually pick out the people who have the kind of deficits that would lead to treatment responsiveness. Big picture, what did we think we found with this? Well, persistent damage in and dysfunction of areas with dense glutamate and acetylcholine inputs appears to be part of the story. We see from the evidence that we have across all of the experimental and human studies damage to cerebrocholinergic nuclei, their afferents, and then information processing and the circuits dependent upon them. And interestingly, a story for another day, yes, secondary dysfunction in other neurochemical anatomic systems, dopamine and norepi, but not as much evidence of a primary dysfunction as perhaps our inferential reasoning from the effects of treatment with drugs that increase dopamine and norepi might suggest. Leading us then to this cholinergic hypothesis of cognitive impairment after TBI, that acetylcholine is necessary for normal cognition. TBI compromises cortical cholinergic systems. That produces post-traumatic cognitive impairments. And if that's true, then augmentation of serocortical cholinergic function may help, at least in part, remediate some of them. And indeed, there's a huge literature on this. At the time that we actually started doing a few of the studies that I will show you, there had been better than 30 peer-reviewed reports describing acetylcholinesterase inhibitors for post-traumatic cognitive impairments, mixed in their findings. And when we then took on, in relation to a multi-center grant we submitted to NIDLR, a meta-analysis of it, in part because an awful lot of them had actually not done good definitions of TBI, had not been consistent in time post-injury at which people were actually brought, with early interventions in the course of recovery perhaps being then complicated by spontaneous recovery in some of the patients who didn't have chronic disturbances. And then lots of problems with the doses that were used, and more importantly, sample sizes. So for those who do this kind of work, if you look at the Cohen's D, the right-hand column, these are crazy variations in the observed effect size. And I would just say, as much as I love the Zhang study, if you see a study proposing a 4.85 Cohen's D, it's a gigantic, it's like almost 5 standard deviations worth of effect from the intervention. That would be awesome if it were the case. Sadly, it is not. The study that we did with John Silver with the largest sample actually suggests, yeah, it's probably a half standard deviation. That's a reasonable effect. That would be, for most of us, a medium effect size of intervention. What was it predicated on? Well, this is a study that we did in the early 2000s, published in Neurology in 2006. This is a group of persons with mostly, by any measure, severe TBI. Several weeks of loss of consciousness, a month or two of post-traumatic amnesia, most of whom were seen several years after TBI with chronic cognitive problems. For a story that I won't go into detail about, the approach to this study ended up in part informed by Levin's work with cholinesterase inhibitor physostigmine and attention, randomizing people on attention, memory problems, or both. And it was in fact negative as a function of that. However, when we looked at the memory impaired subgroup, think again about CH1, CH2, selective vulnerability to hippocampally mediated function, indeed, rivastigmine improved memory and speed of processing. The next biggest study that follows would call that into question. This is our rivastigmine transdermal patch study, Olga Brahman-Mintzer, the PI based in South Carolina, the RIVET study, which is a negative study. Now, very complicated story about how this was done in the VA in outpatient centers, not part of the VA polytrauma system, in order to get more typical looking vets with chronic complaints in cognition, mostly mild TBI, and as is so often the case with lots of other co-occurring conditions and complications, depression, PTSD, anxiety, alcohol dependence, sleep disturbances, and with regard to the depression and especially the PTSD, highly symptomatic. This was known, or at least much discussed, as a risk, a threat to the test of efficacy. Had we, when we were doing it, the benefit of this meta-analysis from Uderik et al., published in 2022, we might have changed gears. But indeed, from this, we learned depression in especially mild TBI has a very robust effect on cognition. That heuristic I showed you earlier, I showed you for this reason, if not none others, that indeed depression, anxiety, and especially PTSD greatly affect verbal memory after TBI, and particularly in mild TBI. So if one is going to go after those with a cholinesterase inhibitor, one needs to be sure that in fact the memory problems are not accountable in part or even in whole to this problem. And again, the Cohen's d on this being about 0.4. That's a big hill to overcome with a drug that might only have an effect size of 0.5. Again, why? Because if we're not giving it to persons who in fact have a cholinergic deficit as the foundation for their memory problems, we risk pushing them over the edge and making them worse. And in fact, that is indeed what happened in this study. Mild TBI with polyetiological cognitive symptoms were in fact not helped. They were made worse with this. So the multi-center evaluation of memory remediation in TBI with donepezil, or the Memory TBID study, done across 4 sites, one of which was Spalding Harvard, with Joe Giacino and Ross Safant as the local PIs here. I had the good fortune of leading this charge, funded by Neidler, no drug company involvement. 4-site randomized parallel design study, 10-week trial, seeing if we could with donepezil, 31 cents a day, reasonably affordable, even if medical insurance is a challenge for people. Once a day dosing, if you will, 2-step titration, 5 milligrams for 2 weeks, then up to 10, in this parallel arm design might actually improve cognition. We had fairly clear criteria for bringing people in, unequivocally diagnosable TBI, mostly with severe TBI, hospitalization, inpatient rehab requiring, avoiding some of the concerns or confounds in mild TBI, and really wanting to make sure they didn't have any of those other categorical psychiatric diagnoses that might better explain, in part or in whole, the cognitive presentation. We also then applied the usual good clinical practice that you would to selecting people for these medications so as to minimize the risk of treatment-related harms. This is, again, a group of mostly severe TBI, 95% in the drug group, 87% in the placebo group, who had unequivocal impairment measured against their own WITAR-assessed baseline for themselves, deficits in the 40 to 50% relative to expected performance without depression, without anxiety, without other significant co-occurring psychiatric disorders. And much like in the original study with John Silver, saw an effect size in the MITT and per protocol analysis of about 0.46. And in the responder analysis, half standard deviation or better improvement, number needed to treat of 3.5, number needed to harm 6.25, giving you a likelihood to be helped or harmed ratio of 1.79. If they responded on the primary outcome, which was HVLTR and new learning, they brought recall along for the ride, they brought delayed recognition along for it, retention, and really importantly, processing speed. Very much the findings we saw in the original Silver study, with signals of executive function as well, but underpowered to detect it. Why, having made that comment about the amygdala from CH4 before? So it turns out, in the biostatistician Jesse Ketchum and I spent more hours than I'd like to actually admit saying, I don't believe this finding. We need to get this out of the way. What can we do to covary it out? Well, we couldn't. So anxiety was actually significantly reduced by the intervention. Mind you, we didn't randomize people in on this, so it's preliminary. But interestingly, disinhibition. And if we conceptualize disinhibition as a failure of social cognition, CH4 supporting lateral orbitofrontal cortex, that actually makes some sense. Social cognition, much like their memory problems, being benefited by treatment. And importantly, actually reasonably well tolerated by everybody in the study. We had a dropout of 3 patients, which gave us an 8.1% rate of donepezil discontinuation. It's actually better than the meta-analysis rate we found of about 14%. With diarrhea and nausea, not surprising to anyone who's used this in clinical practice, being the major trouble. It was interesting, we've kept the investigators blind to some of these problems unless they required clinical intervention, but in the analysis, again, CH5, CH6 was nearly a blind breaker in the data. Turns out when you give donepezil to somebody who actually is responsive to it, they end up having that REM generator come online and have very vivid dreams. An interesting early effect often before they have the cognitive changes. This finding intersects nicely with what Deb Warden and subsequent studies have suggested, and in the INCOG 2.0, Bologna 2022, that these drugs, this cholinergic augmenters, and especially donepezil, probably play an important role for us in cognitive rehabilitation, but especially in memory rehabilitation and when there is a functionally relevant impairment that might benefit from cholinergic augmentation of their cog rehab. And I think that's a really important lesson for this, that we have suggested I think we've demonstrated the ability of this category of medicine to bring the structural and functional neuroanatomy back online such that there are neuropsychological improvements. But to make those improvements in everyday life, it really has to be coupled to some kind of cognitive rehabilitation that helps them apply those improvements in what they do in day to day. So what I hope we've done in these 50 minutes is to talk a bit about the relationship between cognitive impairment and cholinergic function after TBI, to start with observations made in clinic, ask questions about what might be the mechanism of that, go down the rabbit hole of figuring out whether there's a foundation for it, and having tested it in the lab to come back to, with a single site and then multi-center RCTs, a test of that. And if useful, then to actually ask, how do we deploy it? I think what we can say based on the evidence that we have is this is something to consider putting in our armamentarium, but it's not for everybody. Based on the evidence we have right now would be, number one, if they have co-occurring problems that might actually explain their cognitive presentation or part or whole, that's where the money is first. Depression and cognitive complaints after mild TBI, go after the depression before we start with cognition-specific treatments. Or at least have those cognition-specific treatments be non-pharmacologic while actually getting the pharmacotherapy of the depression online. Better, the evidence, much like the INCOG 2 group would suggest, is for persons with moderate or severe TBI who have chronic verbal memory impairments, that's the target to start treatment with these medications. Not attention, not executive function, or at least not in the absence of verbal memory problems that are functionally impairing. What I hope we'll see next in the iteration of this line of inquiry is that cholinergic augmented cog rehab, as is suggested by the INCOG group, but for which we don't actually have good evidence yet. And I hope, David, maybe I can be back in 10 years and tell you about that. Right. This is work that's required a tremendous number of collaborators and a lot of funding over a lot of years, and we'll make sure we say thank you to all of them. In the slides, which I'm happy to have everyone get if you want them, selected references, and happy to take a few minutes of questions. Thank you.
Dr. Arciniegas, that was phenomenal. A real tour de force in terms of the brain behavior relationships, the neuroanatomy, and clinical trials. Questions from our audience?
If I covered all of it, I guess. Oh, yes, Bruce. Good to see you, man.
So, fine lecture, knowledge gained. Thanks. Oh, can you hear?
My rock and roll ears are not quite getting me.
It is on.
Yeah.
I will speak close. Can you hear me now?
I can hear you now.
So, nice lecture.
Thank you.
Knowledge gained, and thanks, David. Just looking at CTE, maybe related to your topic, and Alzheimer's, and studies that have shown that have suspected common genetic vulnerabilities and perhaps autoimmune processes. Any trace of the genetics and possible autoimmune process in traumatic brain injury?
Oh boy, it's a lecture for a whole other context, Bruce. Yeah. Well, and one needs to be careful about what one says about CTE in Boston. There are people more expert in that than me. What I will say from my standpoint, looking at that literature in relation to what we've just gone over, is in this literature, the ApoE genotype does actually seem to be relevant, especially in the moderate to severe. It has not yet been investigated in relation to cholinergic treatment responsiveness, but that is something that should be looked at. As regards the intersection of these chronic problems and what then becomes CTE, again, I think there's a gap between these things that needs to be filled with evidence. As regards the genetics of CTE, I think while we tend to talk about it as a tauopathy, as we know it's a combined tau and beta amyloidopathy, It has struck me as an observer to that literature that most of the genetics of FTD, whether it's FUS or GRN or CORF79, have not yet been applied to in the way that I think they need to be to actually ferret out who is it in this population that goes down that pathway? And is it one where genetic risk for that neurodegenerative course would actually be reasonably predicted by the genetics they brought into their injury? Again, it not just being about the injury or repetitive injuries, but also the kind of brain that was injured. That seems like an important variable to explore.
Thank you, Dave. That was fantastic, and I learned a lot too. I wonder about, we see similar evidence for the benefits on cognitive testing of cholinergic augmentation or replacement in Alzheimer's dementia and dementia with Lewy bodies, but we're often disappointed by how that translates into daily life. And I just wonder if you could make a few comments about some of the ranges of responses that you've heard your patients and families describe in terms of the impact on their daily life.
Yeah, I mean, it's interesting because just to comment on that quickly, Brett, obviously the work that we did in this was predicated on the drug development efforts in Alzheimer's disease. And in the best of the meta-analyses in AD, the effect size for the cholinesterase inhibitors is 0.29 optimistically, and in many of them much less than that, 0.15, 0.2. I think that makes some sense because unlike this condition where there's an event and a selective vulnerability and a reduction in neurons, those from the Salmon studies, among others, those reductions are stable after the event. So once instantiated, they're on a plateau. And for some of these, again, who is it that has what we would used to call a Lazaroid response to cholinesterase inhibitors? Not many, but I see more of them in TBI than I've seen in the years in the Alzheimer's or the DLB category. And I guess that makes some sense because at least in AD and DLB, they're on a continued decline. So the likelihood that the drug in those contexts and its sometimes disappointing effects would be the same in this group, I think would be not expected given that they're on different trajectories in relation to the effect of illness on those cholinergic neurons. Again, I think one of the questions we had as an investigator team in the memory study was, yeah, well, it isn't everybody who responds. It's about half of the people who got the drug responded. We didn't see people get worse, which is actually reassuring that we'd at least people out we had selected out people who really did have a deficit and or some selective reduction in cholinergic tone such that we didn't make most of them worse. But who were the responders? I don't think we have yet from this study or others the data we need to actually do that prediction of the Lazaroid responders. Hopefully we'll get it. Hope that answers the question. Okay, one more. Okay.
Again, thanks for the brilliant lecture and also for showing the alarming epidemiology of TBIs. So a couple of questions. One, have we improved prevention, especially on when we know people will hit their heads, right? So professional sports and vehicle crashes and so on. And the second is an approach on how to take care of these patients. As you show here, it's so complex to find something that really benefits in the short term. So these patients are with us for a long time, and how to triage and kind of have them better or cared for in the long run.
Yeah, it's a lot in that question to unpack. I'll see if I can quickly do it. So the epidemiology of TBI would suggest that we have actually made some progress in prevention, or at least awareness and early intervention, so that as people have concussions, what to expect to get better, and if not getting better, get into clinic to help facilitate recovery without developing an identity as someone with a brain injury can be very helpful. That self-identity ends up being something self-labeling that sets an expectation for continued problems rather than continued recovery. The data on whether or not we've done much in the rest of the world to reduce brain injury is a little more complicated. It turns out that putting seatbelts in cars made a huge difference. Putting airbags in cars made a difference. Made mostly a difference in survival. And the challenge then is we have more people who are surviving what would have been previously fatal injuries to then accrue into the disability category. That makes this kind of work, I think, that much more important, that if that's the case, then we really need interventions, non-pharmacologic and pharmacologic, to help improve quality of life, everyday function, truly long-term outcomes in people with these problems. That is, as you can see, clearly a work in progress.
Dr. Arciniegas, thank you so much for sharing your expertise with us. It's been wonderful to have you visit.
Thank
Big
you
thank
very
you.
much for having me. Appreciate it.